Okay. Hey, everyone. Um, so my recording from our class today didn't end up working out. I couldn't find it or um, get it downloaded. So I'm just going to make a new one so you guys can still have the content that we talked about. So remember we talked about diabetes. So I'm going to put up the PowerPoint that kind of went with that so you can get a better idea of what I'm talking about as I'm talking. So just give me 1 second here. All right. So remember we said with diabetes that um, it's really a common thing here in the United States. So it's the leading cause of non-traumatic amputations, blindness in working age adults, and end-stage kidney disease. So there's some risk factors for diabetes that we kind of talked about as well. So some of those included um, just being obese, your race. So if you're African American, Mexican American, American Indian, Native Hawaiian, Pacific Islander, or Asian American, you're more at risk. If you are, if your age is equal to or greater than 45 years old, you're at high risk. Hypertension puts you more at risk. History of gestational diabetes, or delivery of a baby over 9 pounds. If you have your high density lipoproteins, your cholesterol level is elevated, or your triglycerides is elevated, that's going to put you more at risk. Okay, so what is diabetes? It's a complex multi-system disease characterized by the absence of or a severe decrease in the secretion or utilization of insulin. All right, and then this just gets into a little bit about the pathophys. So the primary function of insulin is to facilitate the movement of glucose from the blood into the cell. This decreases the blood glucose level altogether by doing that. This is necessary for the transport of glucose into the cells of the liver, muscles, and other tissues. This regulates the rate of carbohydrate metabolism and conversion to glucose. Normally, insulin is decreased during fasting and increased after eating, which would be prandial. Okay, insulin is secreted by the beta cells in the islets of Langerhans in the pancreas. Insulin allows the body to use carbohydrates more effectively for conversion of glucose for energy. There may be adequate intake of carbohydrates. There should be, when we're talking about this. And there must be available insulin to facilitate the movement of glucose into the cells. There must be adequate reserves of glucagon as well. This is released by the pancreas and it converts glycogen to glucose in the liver. So if carbohydrates are not available to be used for energy, cells will begin to oxidize the fats and protein stores. So this causes a breakdown of fat and it results in the production of ketone bodies. Proteins that are wasted during insulin deficiency, when we talk about that, they're broken down and converted to glucose by the liver. This contributes to the increase in circulating glucose. When fats are used as the primary energy source, the serum lipid level rises and contributes to the accelerated development of atherosclerosis. When circulating glucose can't be used for energy, the level of serum glucose will increase, so it will cause hyperglycemia. Hyperglycemia will cause an increase in the osmotic gradient. Water moves out of the cells into the circulating volume to decrease the osmolarity. This results in an increase in urine output. The increase in circulating glucose exceeds the external threshold and glucose spills into the urine. So what's the basis for these symptoms? So typically we talk about those 3 Ps: polyuria, polydipsia, polyphagia. Polyuria means that you're putting out lots and lots of urine. This is because of that increased serum osmolarity. There's more circulating volume and water is not absorbed from the renal tubules, and there is a significant increase in urine output. Polydipsia means that there's an increased loss of fluids that precipitates dehydration, causing thirst. Polyphagia means that there's a tissue breakdown and wasting that causes hunger. And the last thing I have on here, it talks about weight loss. This is something that you might see that goes along with type 1 diabetes. So glucose is not available to the cells, so the body begins to break down fats and protein stores for energy at that point. Okay, so this is where we start getting into the different types of diabetes. So the first one is type 1. The beta cells are located in the islets of Langerhans. They just don't work. So therefore, the body doesn't release any more insulin, and for treatment, the patient must use insulin. Risk factors for this would be, hey, it's genetic. Maybe you got it passed down from your dad or your mom, or a lot of people say there is an autoimmune component to this, that your body's trying to attack itself, and that's why you have this. This is not related to lifestyle like type 2 diabetes is. There's absolutely nothing this person can do to prevent this. So, this can just come on, suddenly, and you just have no control over it. So what do patients look like clinically? They usually are young and thin, not always, but usually. And this comes on suddenly, like I said, so it doesn't happen over a period of time. And then ketones will be present in the urine. When we talk about type 2 diabetes, with type 2, your cells quit responding to insulin. So the patient has an insulin resistance. So this leaves all the glucose floating around in the blood, and the pancreas senses this. It senses that there's all this glucose present in the blood, so it releases even more insulin. Due to this, the patient starts to experience hyperinsulinemia, which is caused by metabolic syndrome, which we'll talk about here in a second. So treatment for type 2. Usually this is all lifestyle related. So diet and exercise is the first line treatment. When that doesn't work, then you go to oral meds. And usually from there, like if the one oral med doesn't work, they might add another. And then if that doesn't work, maybe they'll stick you on insulin. So type 2 diabetics may need insulin during stress, surgery, or infection. A lot of times you'll see people go into the hospital and they'll be like, oh, I just take oral pills for my diabetes. I don't understand why they're giving me insulin. And you would say, well, it's because of the stress from the surgery that's causing your sugars to be out of whack. So you need this insulin for now until you get through this stress. That's what you would say. Okay, risk factors for type 2. Again, all about lifestyle. So being overweight, sedentary, poor diet, you drink lots of pop and sugary type drinks, you may have a lot of stress, and also there is a little bit of a genetic component to this as well. Usually this type of person who has type 2 diabetes is overweight. this happens over a period of time, so it's not overnight like something like a type 1 would be. It usually happens over years. These guys usually don't have ketones in their urine because they don't have the issues with carb metabolism. And then typically, like we said, with stage 1, or not stage 1, but type 1 diabetes, you're typically younger. Usually it's like younger onset. This usually is a little bit older, so adult aged people. All right, then we get into gestational diabetes. But before that, let me just real quick remind you about metabolic syndrome. So we just mentioned metabolic syndrome with type 2. So what is it? It's a group of risk factors that's associated with development of cardiovascular disease and type 2 diabetes. So if you have a patient who has these 4 things, then you're going to be like, oh, they have metabolic syndrome. I've got to, do something about this. So the 4 things would be high blood pressure, high blood sugar, unhealthy cholesterol levels, meaning that they would be high, and then increased abdominal fat. So this person's going to be really big around the middle. So typically they have like a body shape that's like a pear shape or an apple shape, if you've ever heard that term. So metabolic syndrome is linked to being overweight and with inactivity. So what you would do for this is you would really do some aggressive teaching with this person to try and get them to change their lifestyle. So they need to eat better, they need to be more active and exercise, and hopefully this will get better. All right, so with gestational diabetes, this is similar to type 2. So it's when the cells are not receptive to insulin, and it typically goes away at birth. So as the baby grows, the placenta produces more and more insulin, and it's counteracted by hormones that your placenta produces, and it raises your blood sugar. So it's really all about these hormones having to do with your placenta. So as you go through your pregnancy, if you are diagnosed with gestational diabetes, typically, depending on how bad you are, so if you're like really way off with your sugars and they're really out of whack, then they'll probably have you on medication. But if it's just slightly off, then they're just going to have you change the way that you eat and like really keep a close eye on your sugars. So that's kind of what they did with me. So I had to meet with a dietitian and I had to meet with a diabetes educator. And they, just told me how to look at everything and how to get the right amount of calories and all that kind of stuff. So with this, it's usually diagnosed between 24 and 28 weeks gestation. They usually do an oral glucose tolerance test. And like for me, mine was only 2 points off, and they still said I was gestational diabetic. So the worry is that if this person has diabetes, that they're going to have a big baby. And this baby is going to probably be hard to deliver because it's so big. And then also the baby is going to be, you're worried that the baby's going to have problems with their blood sugar. So after they're born, you definitely always check their sugar, for a little while there to make sure that they're okay, because they could, have problems. For the mother, she is more at risk to have this again in future pregnancies if she gets pregnant again. And then both the mother and the kid is going to be at risk for type 2 diabetes later on in life. So that's definitely something to remember. Okay, and then just talking generally about assessment findings that you would see with someone with diabetes. So yes, you're going to see a really high blood sugar, right? So hyperglycemia, but you're also going to see those 3 P's. So the polyuria, they're going to be, peeing up a storm. This here just kind of, tells you why that is. And then Polydipsia means you're very thirsty. You know, if you are putting out a ton of urine like that, you're going to get really dehydrated. So that's going to be why you're so thirsty. You're trying to get all of this water. And then the polyphagia, you're very hungry. And this is typically because you're burning fat for energy. And that's why you're so hungry, because of that. So typically weight loss is associated with this too. Other things that you would see for assessment findings. So typically diabetics have slow wound healing. They may have problems with their vision. So typically blurry vision because of damage from glucose with their eyes. You could see glycosuria, meaning the kidneys can't reabsorb all the extra glucose. You could see an acetone smell in the breath from burning ketones in a type 1 diabetic. These guys are going to be at risk for rashes on the skin, dry and itchy, repeated vaginal infections because the yeast loves glucose. All right, in order to diagnose someone as diabetic, there's certain criteria. So you have to have 2 or more abnormal test results with 2 or more values outside the normal range. So I have 3 tests listed here. So there's one called a fasting blood glucose level. This would be if you, like, say you're nothing by mouth after midnight and you go and you get your blood drawn in the morning. So a fasting blood glucose means that you haven't ate or drank anything, for quite a while. So if it's above 126, that would be, a positive result for diabetes. Again, you don't just take one result, you have to have 2 or more values outside the normal range. With the oral glucose tolerance test, that's the one like they would do for gestational diabetes. This is a 2-hour glucose value, and if it's greater than 200, that means that it's positive. A random glucose would be another one that would be greater than 200, but you also need to have symptoms associated with that. So like if you're having, polyuria or something like that along with it, then yeah, that's saying that you are diabetic. Okay, so getting back a little bit to pre-diabetes. Pre-diabetes is an intermediate stage between normal and diabetic. So maybe this person had an impaired glucose tolerance test where their plasma glucose is greater than 140 or higher during an oral glucose tolerance test. They could have an impaired fasting glucose where maybe it was just a little bit high. It was between 100 and 126. And then we mentioned earlier in class about the glycosated hemoglobin. Excuse me. So this is the hemoglobin A1C. So with this, typically a normal one is between 4 and 6. But what it is it's the level of what it is, it's the measure of glucose control over the last 3 months. So when blood glucose levels are elevated, glucose molecules will attach to hemoglobin in red blood cells. The longer the amount of glucose in the blood remains above normal, the more glucose binds to hemoglobin and the higher the A1C becomes. So if you have a patient who is diabetic, you want their A1C to be below 7. You already know it's going to be abnormal, but you don't want it to be super high. So below 7 is usually acceptable. All right, and then we talked a little bit about physical activity and how that's so important. So exercise is very important for the diabetic. So when you exercise, it actually will decrease your blood sugar. Typically, physicians will tell you to exercise at least 3 times a week with no more than 2 consecutive days without exercise. They also, it's really important for them to inspect their feet all the time because a lot of times diabetics get that diabetic neuropathy where they have numbness and tingling in their feet. And so they may not realize that they have a problem with their feet because they don't have feeling there. So if you just kind of associate it with your exercise, then after you do your exercise for the day, you take a look at your feet and make sure that they're doing okay. They say to avoid exercise in extreme heat or cold, avoid exercise during periods of poor metabolic control, and then also make sure you stretch for 10 to 15 minutes before you exercise. So the reason that you should not exercise when your blood sugar is already high is because it will go up even higher because you're already out of control. So if you exercise with a high blood glucose, it increases secretion of glucagon, growth hormone, and catecholamines. The liver then releases more glucose, and as a result, it increases your blood sugar. So it's always a good idea for a diabetic to take their blood sugar before they decide to go exercise to make sure it's, under control and doing well. Um, so also diabetics should make sure that they eat a 15-gram carb snack before they exercise to prevent unexpected hypoglycemia, because that could be a thing that you can see as well. Okay, this also talks about the diabetic diet. So when you talk about the diabetic diet, your physician usually will tell you to be on a certain amount of calories per day. So like it's not uncommon to see someone on a 1600 ADA diet or an 1800 ADA diet. What this means is that person needs to have that amount of calories per day, per 24 hours. And the ADA just stands for American Dietetic Association. So some things you would want to teach your patient that is diabetic just about eating and like their habits. They need to learn how to read food labels so they know, kind of what to look for. They also need to know how to count carbs, especially if they're going to be someone like a type 1 diabetic where they definitely need to be able to do that. And then you can teach them about exchange lists. So exchange lists are like, they compare things. So maybe there's something that is kind of comparable to something else that you might want, but it will be better for you and it won't be as sugary and make your sugar as high. In my other book from my other class, they talk about the glycemic index. The glycemic index is how much a given food increases your blood glucose level compared with an equivalent amount of glucose. So the idea is you want to have diet therapy where you avoid sharp, rapid increases in your blood glucose levels after you eat. So the glycemic index, you would just want to stay with foods that have a low glycemic index instead of things that have a really high one. On this slide, it also talks about recommendations for, like fiber and saturated fats and that kind of thing. And then also portion control is a big deal too. Okay, so then it gets into treatment. So the first thing is insulin that we're going to talk about. So the first one is rapid acting insulin. This is talking about Lispro, Aspart, and Glucine. So the other name for Lispro is Humalog, and the other name for Aspart is Novolog. And I couldn't tell you the other name for Glucine, I just don't have that written down. But the things with the insulin, you really need to kind of memorize the onset, peak, and duration for every one of them because it's very important. It helps you be able to answer questions appropriately. So when we talk about onset, Onset means the length of time before insulin reaches the bloodstream. And then the peak means it's the time period where insulin is most effective. And then the duration is how long insulin works for. So with rapid acting insulin, the onset is 15 minutes, the peak is 60 to 90 minutes, and the duration is 3 to 4 hours. So this should be used in combination with intermediate acting insulin only. And the routes of delivery for this would just be subcutaneous. The next one is regular or short acting insulin. The onset for this one is a half hour to 1 hour. The peak is 2 to 3 hours, and the duration is 3 to 6 hours. Usually, this is given 20 to 30 minutes before meals, and a lot of times you'll see this used with a sliding scale. And for this one, you can give it subcutaneously like all the other insulins, but this is the one that you can give IV. So out of all of the insulins, this is the only one that you can do that with. And then also regular insulin can be mixed with, like NPH or something like that. All right, and then NPH is our intermediate acting insulin. This is the cloudy, all the other ones we have are clear. This is the only one that's cloudy. So the onset is 2 to 4 hours, the peak is 4 to 10, the duration is 10 to 16, and it says hypoglycemia tends to occur in mid to late afternoon. And then you should only give this subcutaneously, and it can be mixed with regular insulin. For the long-acting insulin, Glargine and Detamir are the names of those. And people are really bad about remembering names of insulin, so that's why I put these other names on here so you can kind of get an idea of what we're talking about. So the other name for Detamir is Levemir, and the other name for Glargine is Lantus. So that's usually how people know those. With this one, the onset is 1 to 2 hours. It doesn't have a prolonged peak, and the duration is 24 hours plus. You cannot mix long-acting insulin with any other type of insulin. Usually, this is a once-a-day insulin. However, the one kind of long-acting, the Detamir, can be given twice a day. So, it's not uncommon to see it given in the morning and the evening. In long-acting insulin, also, you only do subcutaneously. We did talk a teeny bit about insulin pens in class today. We said it's basically just like a pen itself. However, you have to screw on the end of it a needle every time you go to give a shot. So that needle is a one-time use. So you don't keep using the same needle. You always get rid of it and put a new one on every time you give yourself a shot. So the needle itself, it's real easy. It's just one that you screw onto the end, and then it has 2 caps to it, then the outer one and the inner one. The outer one is the one you save, the inner one is the one you get rid of. So this also has a dial on the end of the insulin pen. So every time you go to give someone a shot with an insulin pen, you always should check and make sure that the pen works appropriately first. So they say that you're supposed to do what they call an air shot. An air shot means that you give, you dial up to 2, and then you hold it up in the air, and then you hit the button on the end, and you watch as a little bit of insulin squirts out the end of the syringe. And this will show you that the pen is working appropriately. So that's an air shot. And then after you're done doing that, you can go ahead and do, dial it up to whatever your order is for. So if it's to give 10 units of NPH, you're going to dial it up to 10. And then to give it, you give it just like you would any other type of shot, with that darting motion. And remember, we're going in the subcutaneous tissue, so you can bunch up the skin, and you can go in, and as you go in, you're going to hit that button on the end, and the button will administer the insulin, and then you let it sit there inside the skin for like 10 seconds before you take it out, because that gives it time to absorb and do what it's supposed to do. Okay, so complications of insulin therapy would be lipoatrophy and lipodystrophy. So basically, if you keep going in the same spot all the time, you're either going to get like some fat areas that kind of build up, or you can get some loss of fat tissue because you keep going in the same place. So it's always a good idea to make sure you put it in different spots so you don't have these issues. Okay, oral hypoglycemic agents, there's a ton of different categories, and I get it that they're hard to remember, but you have to try to start getting this. Sulfonylureas is one of the categories. So these tend to end the same way, like IDES, ZIDES, MIDES, RIDES. So like, for example, glyburide or glibazide, those are typical examples of sulfonylureas. So what these do is they stimulate the beta cells in the pancreas to make insulin. So you want to avoid alcohol while you're on this, and also this can cause, extreme hypoglycemia, so you have to be careful. The metaglinides end in glinide, so you'll be able to pick that out, no problem. This one you want to take with the first bite of your meal, so you definitely don't want to take it beforehand. You want to make sure you're eating and then take it. Biguanides are, your biggest example is metformin or glucophage. What this does is it causes the liver to decrease its stores of glucose. You want to watch out if the patient is scheduled for surgery or a procedure that has like IVP dye that they have to get, because the IVP dye will affect your kidneys, and then so does the metformin. So it's going to make it even worse. So typically, if you have to go for something like that, they stop this medication for 48 hours before and 48 hours after to make sure that your kidneys are okay. So you definitely have to watch renal function in this drug. And then there's a couple others there at the bottom that you guys can read through. Okay, then we talked about the dawn phenomenon. What this is it's towards the early part of the morning, the crack of dawn. So this is the time when the body will increase the blood sugar in preparation for waking. However, when you have an insulin problem, the increased blood sugar causes hyperglycemia. So typically this is going to happen between 5 and 8 in the morning, and you may need to have a nighttime dose of NPH to counteract this from happening. Then there is the Somogyi effect. The Somogyi effect is, again, something that's going to happen early in the morning, but this is like, you know how we said you want your blood sugar to stay even keel and to not have big spikes or down, low lows as well. So what happens with this is early in the morning, about 2 or 3, you have a drop in your blood glucose. And this happens when the body releases hormones. But then as a result of the release of these hormones like cortisol and catecholamines and growth hormone, now you start to have an increase in your blood sugar. So you go from really low to really high. So this is kind of a problem because, again, we're having like this yo-yo effect with your blood sugar. So typically they say to eat a bedtime snack. A dose of bedtime insulin might help prevent this from dropping so low or decreasing insulin amounts at night. And then we did talk a little bit about hypoglycemia. So let's get into that again. So hypoglycemia typically is going to be when your blood glucose is less than 70. And like I said earlier, it's going to depend on what your Lewis book says. So make sure you go with what that book says, because typically all of your questions are from that book. So, and again, too, when you actually are out in the field and you're working, every facility is going to be slightly different, so just go with what your facility says. So typically, your signs and symptoms of low blood sugar, some of the things that you would see, typically excessive sweating is like a big one, inability to concentrate, headache, lightheadedness, confusion, memory lapses, numbness of the lips and tongue, slurred speech, impaired coordination, emotional changes, irrational or combative behavior, double vision, and drowsiness. So it's kind of a scary thing sometimes when you see someone's sugar drop. Um, you always hope that your patient can kind of give you some type of warning that this is happening. So if your patient's able to tell when their blood sugar goes down, that's always super helpful because then it's not a surprise to you. And they can kind of, prevent it from happening. However, sometimes you'll have patients who have no warning whatsoever and their sugar just goes down, real easily. So that person, you'd have to really keep a close eye on. So typically the treatment for this is going to depend on how the patient presents. If the patient is awake enough to be able to follow directions and they can swallow and chew and have no issues with that, then you're going to give them something orally. That's always preferable over, giving them like an IV something or, some type of other medicine. Because again, we want to keep their blood sugar even keel instead of having it be really high or really low. So typically you're going to reach for something like an orange juice or an apple juice, glucose tabs, or even like a pop or something. If you give soda pop, you don't want to give a ton of it. You only want to give maybe 120 milliliters. And then, hopefully that'll be enough to bring their sugar up to where you want it. Once you get their sugar up, you definitely still don't want to stop there. You want to give them a 15 gram of a fast acting carb to kind of keep it there. So maybe you go get like, graham crackers and peanut butter, or you go get a cheese sandwich or some milk or something like that. You have to give them something in addition just to keep them up so they don't drop again. So that's always really important. When they go low, you want to take their blood sugar every 15 minutes until it comes up. And you document everything. You document what you did to bring it up, how they responded, all of those types of things. Now, if they can't follow directions, if they're really out of it, then you may have to bring their sugar up, like more drastically. So in this, like maybe they're 20 when you go to take their blood sugar and they're out of it and they can't follow any directions, then you are going to go reach for D50. D50 is a medicine that you would give that you get out of the Pyxis machine, and usually it comes in this big box and it has like a huge syringe to it, and it's something you would give IV push. This is super thick, so if you ever get a chance to push this on someone, you'll never forget it. You don't want to push the whole amount. Typically, you only do half of it, and usually it's going to make your IV go bad because it's, like I said, it's super thick and it's hard on the vein. So just expect it, that that's probably going to happen. It's probably going to make your IV go bad. So other things sometimes people will complain of, sometimes they'll say they get a headache from it or pain at the injection site. The nice thing about D50 is you can see a change in their blood sugar quickly. So like usually within minutes, you'll see it get better. However, again, we don't like to like really shoot the blood sugar up high. We want to keep it even keel. So even if you get it up from the D50, you still want to give them a little bit of a snack of some sort to kind of keep it so it doesn't drop again. If your facility doesn't have D50, the other thing you could do would be give glucagon. So some facilities, that's what they do instead. So glucagon will prevent the blood glucose levels from dropping to a dangerous level by stimulating conversion of stored glycogen to glucose in the liver. Now, glucagon can come in different ways. You can give it IM, sub-Q, or IV. Just remember that if you give it IM or sub-Q, it's not going to work as quickly as it would through the IV. So you will not see, an improvement in their blood sugar for probably a good 20 minutes. With glucagon, you can repeat a dose of it if you have to, so in 15 minutes. And they say to give supplemental carbs, afterwards as well to make sure that you keep their sugar up. So just be aware that those are two things that you could reach for in an emergency if you had to. All right, other complications that you could see from diabetes. It just causes so many problems, but it hardens the arteries. So you get atherosclerosis as a result of this. So you get all of this plaque buildup inside of your arteries and vessels, and it's going to cause lots of problems. So it can cause heart disease, you can get a stroke from this, hypertension, neuropathy, poor wound healing, like we said before. And then also you can get eye trouble, infections, you can have kidney issues, you name it. Okay, and then we talked a little bit about DKA, so we need to talk about that again. So DKA is a complication that you can have when you have diabetes. And typically there's going to be three main reasons why you get this. One of the main reasons would be a missed dose of insulin. So typically, a lot of times when diabetics get sick, sometimes they will just purposely not take their insulin. And if that's the case, what do you think happens to their blood sugar? It goes up. So, that's part of the problem. So that would be one of the causes. Another thing would be illness or infection. So typically, something is going to set them off. So like maybe they have an abscess or they have a pneumonia or something along those lines that's causing them to go into this. And then the third thing would be undiagnosed or untreated diabetes. So maybe they don't even realize they're diabetic, and this is how they figure it out. So usually this is what happens with type 1 diabetics. Maybe they've never had an issue before until they go into DKA. So what happens with this then? Again, you have something that kind of kicks you off into this, or maybe you just didn't take your insulin. And then because you don't have adequate amounts of insulin in your system, you can't get glucose into your cells to give you energy. So what happens? Your glucose, your body tries to like metabolize your fats, right? And so you start to get hyperglycemic. So your blood sugars start to go up, and your body sees this, that your blood sugars are getting high. And so it causes the kidneys to excrete glucose along with water and electrolytes because it's trying to compensate for this. And so because we're peeing so much, we're getting rid of our electrolytes out with it. So now we're going to be dehydrated and we're going to, have this electrolyte issue. And then when this happens, you get dehydrated, like I said. So you would also see a deficiency in the breakdown of fat. So this is you're going to see free fatty acids that are converted to ketone bodies. These are acids and they cause metabolic acidosis. So a couple of big time signs and symptoms then of DKA would be, yes, I'm going to have a high blood glucose, and typically it's going to be greater than 300. Usually I'm going to be a type 1 diabetic if I have DKA. A lot of times you will have, extreme dehydration, you'll have electrolyte issues, you'll be in metabolic acidosis, you'll have the ketone bodies, you'll probably have acetone smelling breath, you usually have Kussmaul respirations. So those are kind of the big things to watch for. And then we also talked about a little bit about HHNS. HHNS is hyperglycemic hyperosmolar non-ketotic syndrome. This happens mainly in type 2 diabetics, and it presents with hyperglycemia without the breakdown of ketones. So it's basically the same thing as what we just talked about, but the body doesn't go as far as to break down fats for energy. It stops right there. So you still have that osmotic diuresis, you still have a high blood sugar, you still have loss of electrolytes, but it just kind of stops there. So treatment is going to be the same for both. Again, you treat both of these with IV insulin. You're going to treat the symptoms. So yeah, you're going to treat the dehydration with IV fluids, and you're going to have to watch what kind of IV fluids you give at first. And then as you watch your electrolytes and everything improve, then you're going to switch the IV fluids to something else. You are also going to treat the metabolic acidosis. So sometimes you'll see people get bicarbonate. If this person has messed up electrolytes like a high potassium, which usually they do, you are going to give them things to get their potassium down. So maybe you'll give Kayexalate or something along those lines. Now, the thing I want you to remember with HHNS is your glucose levels are really high with this one, like higher than with DKA. So like greater than 600. The other thing with this is typically it affects older adults more so than younger people, people with type 2 diabetes with this one, and you also will get neuro symptoms. So typically they start getting confused or something along those lines, and that's what brings them in to get looked at. All right, and then the last slide talks about sick day guidelines. So we said it's super important when you are sick to make sure you don't skip your dose of your insulin or your medication. You always need to take it unless your physician tells you differently. When you're sick, you also want to check your blood glucose levels every 3 to 4 hours and urine ketones when you go to the bathroom, if you're like type 1. If you can't eat and have replaced 4 to 5 meals with liquids, notify your healthcare provider. And the things that the healthcare provider will tell you to drink would be things that are high in carbohydrates. So every 4 hours, or excuse me, not every 4 hours, every hour, you should drink fluids that replace electrolytes. So fruit drinks or sports drinks, soups, regular soft drinks, stuff like that. So that's that PowerPoint. So hopefully that helps you kind of hit some of the highlights of things that you need to know for diabetes. There's probably a couple of other things that maybe I didn't mention, but for the most part, I think I got most of it for you. So if you have any further questions, just let me know and I'll do my best to answer. Thanks.